Thank you very much to the chairman and to the organizers of the meeting. It's always a pleasure to come to beautiful Krakow. I think this is my 7th visit here, and it gets better every time I come. I love to come here to Krakow. It's just a beautiful city. I'm going to be speaking about one of the latest exciting areas in the area of myeloma. You know, there's MRD is a big topic, hot topic everywhere. Bispecifics, which I'm sure one of my colleagues is going to speak about, and CAR T cells. Those are the main thrusts of research interests in recently in the field of myeloma. And over the last 10 years that we've had this conference, the growth in and expansion of information in myeloma has just been overwhelming. So, and we're fortunate to have some excellent speakers here that are going to deal with many of these very exciting areas in myeloma. Today, I'm going to deal with MRD, but I'm going to start off with a little bit of a history lesson. So I know you can't see this slide very well. I'm not going to expect you to, especially those in the back. But this is a paper that actually Dr. Hurosou's group from the IFM joined data with the Arkansas group to look at, do you actually cure patients with myeloma? So here I'm going to be talking about MRD, but do we really need to do MRD? The bottom line is do people get cured? Do they stay in remission? So these curves, and I don't want to belabor this because it's small. I don't know, does this pointer work? Yeah. These curves here are from Total Therapy 1. I started Total Therapy 1 when I was in Arkansas with Dr. Barlegi in 1990. So this data for Total Therapy 1 at the time this was published was with a median follow-up of 21 years. Total Therapy 2 is at 16 years. So this was very, very mature data when this was published 8 years ago. But what we see, even without MRD testing, we see a plateau down here of, this is the original Total Therapy 1 group. There's a plateau of 20 years, 20 plus year median progression-free survival of over about 12% of the patients. So this is without MRD testing. So we probably do operationally cure some of these patients. Now, I should also note that in that group, this about 12% of the patients that looks like there's a plateau, they weren't all in complete remission by serologic evaluation at that time. Some of these patients were reverted back to an MGUS state. So when we talk about MRD, you have to keep that in mind, that some of these patients, even though they're MRD positive, may still have very good outcomes. Even though MRD negativity certainly is associated with a better outcome, the MRD positive ones still may have long-term survival. So this is one of the curves that Nikhil Munshi, another one of the Arkansas group from long ago, published in Blood Advances, showing what happens with MRD positivity versus MRD negativity. So this is MRD negative. The red lines are the MRD negative group at 5 years. 51% of those patients are still in remission versus 25% of the patients who are MRD positive. And sure enough, when you look at survival as well, the patients who are MRD negative do better than MRD positive. So this is data I'm embarrassed to actually show, since we've got one of the founders and leaders of the IFM that's going to be speaking in just a little bit. But this is the IFM data from the 2009 trial, and you should all be aware of that. This was just actually updated in the recent ASCO meeting. So they called this trial, they gave it a name eventually besides IFM 2009, just Determination 1, and the U.S. trial was Determination 2. I'm going to give a little bit of plug about this in just a second, no offense to Dr. Hurosou. But what they did is they looked at these groups of patients who were MRD positive and MRD negative, and sure enough, if you're MRD negative, your progression-free survival is better than if you're MRD positive. But what was also interesting about this trial, this data, is if you were MRD negative and you were in the non-transplant arm, which is the top line here, this is the group that didn't get transplanted versus the group that did get transplanted. If you were MRD negative, you actually did about the same statistically with or without the transplant. So I'm actually a transplant doctor as well. I don't like to admit to the fact that if you're MRD negative, that you may be able to overcome the need for a transplant. If you're MRD negative, we're going to talk about can you use MRD for clinical decisions making in a little bit later in the talk. Now, what's also important about this trial is that in the French part of this trial, it was done exactly the same in the US, led by Dana Farber. The French trial only allowed for 1 year maintenance therapy. The US trial allowed for continuous therapy. And again, you're comparing very, very similar trial groups. And in the French trial, and Dr. Hiroso can correct me, I think the median progression-free survival was 47 months. And in the US trial with continuous Revlimid or lenalidomide, it was 67 months. Bottom line is, I'm sure one of the other speakers is probably going to address this. Patients probably stay, he can disagree with me, I don't mind, but you probably should stay on lenalidomide maintenance. It should not be given for a limited period of time. That's my take on that data. So, and that's essentially what I'm showing here. This is the same data, the determination trial that was updated by this is the US part of the determination trial. This is determination 2, and you see the progression-free survival for those who are MRD negative is going to be better than those who are positive, yet the overall survival is similar. So the people that are naysayers against transplant, you can say, well, if you're MRD negative, you don't need a transplant. And even if you do get the transplant, if you get salvaged with adequate salvage therapy, your overall survival is very similar. And this, again, is just outlining what I alluded to before. That was the overall data. This is the MRD data. So this is the RVD without the transplant. This is the RVD with the transplant. If you're MRD negative, your 5-year progression-free survival is virtually identical. The Forte trial, done in Italy, very complex trial. There's 2 different portions of this trial. I don't want to go into all the details about this, but it was everyone got transplanted on this trial. KCD, carfilzomib, cyclophosphamide, dexamethasone, was compared to a proteasome inhibitor with an immunomodulatory drug. And in this trial, there was a no transplant arm versus a transplant arm, somewhat similar to what I just showed you with the IFM trial. The KCD arm, cyclophosphamide, is inferior to an arm that has an immunomodulatory drug. And then there was a second randomization to single lenalidomide or lenalidomide with carfilzomib, a proteasome plus an immunomodulatory drug. And bottom line here is that the group that had the transplant had the superior progression-free survival. And not only that, patients who had a doublet for maintenance therapy had a superior outcome than those who had single agent maintenance therapy with lenalidomide. When you look at MRD negativity, the difference between the transplant and the non-transplant group was about the same if you were MRD negative. So KRD for 12 months versus KRD, transplant, KRD, and then maintenance was about the same. Same was true for those that, for the high risk. When they looked at the sustained MRD though, this is the initial MRD analysis, sustained meaning more than 1 year. It shows that the transplant group had more durable MRD negativity and a superior progression-free survival compared to the KRD. So at initial testing, it looks like it was the same, but with longer-term follow-up, the transplant group did better as far as the durability of MRD testing. When they looked at randomization, this is also important for those of you who are interested in giving after transplant, if you want to give a doublet or a singlet. Let's just focus on the high-risk group. Our standard risk, the likelihood of being progression-free survival was 90% in the standard risk group. High-risk group is 69%. And that is far superior. This is with the doublet of a proteasome and an immunomodulatory drug versus a single immunomodulatory drug with lenalidomide, 73 versus 56. So these were all statistically superior. When they looked at specific, I'm not going to go over this, when they looked at specific cytogenetic abnormalities. In this particular trial, they include the amplifications of 1Q as well as 1P, and across the board, the group that had the proteasome plus the immunomodulatory drug had a superior outcome, except in the 17Bs, which is a bad group. So this was data that was presented a couple times now. This is leading to a potential change in the way we treat our patients, and I'm sure someone else, one of my other colleagues, is going to go over this as well. I only want to focus on the MRD aspect of this, but this trial was not too dissimilar to the Cassiopeia trial that was done in Europe. So in the Cassiopeia trial, they gave Dara-VTD. They had thalidomide instead of Revlimid. And then they had a consolidation as well in that trial, the Cassiopeia trial. So how this would relate to you is this is very similar to the Cassiopeia trial, except they're using lenalidomide instead of thalidomide. And in this group of patients, they did not get daratumumab. And then the group that had daratumumab stayed on the daratumumab throughout, including for maintenance, versus only lenalidomide thereafter. And when they look at MRD negativity, the group that got the DARA plus RVD, when you look at let's just look at the end of 12 months, 62%, the group that did not have the daratumumab down to 27%. So there's no doubt that daratumumab as a quadruplet is associated with a superior progression-free survival compared to the non-daratumumab or anti-CD38 monoclonal antibody. When they look at the MRD negativity, same pattern is seen. End of study, 64% of the patients at 10 to the minus fifth MRD testing were MRD negative in the quadruplet, and in the triplet it's 30%. So we had double the likelihood of MRD negativity with the addition of daratumumab as part of the induction and then consolidation as well as maintenance. MRD negativity does take some time, which is shown on this slide. When you give DARA plus Rev, the MRD negativity is actually fairly quick, that you can see MRD negativity usually by 6 months. It takes a little bit longer even for those patients who did become MRD negative with the triplet. So you get deeper responses faster with the DARA regarding the MRD negativity. And then when you look at different thresholds, again, when you look at 4 drugs versus 3 drugs, we'll just look at this is at 10 to the minus 6 now. The top part here is 10 to the minus fifth. This is 10 to the minus 6, 36% versus 15%, quadruplet versus triplet as far as MRD negativity. And when there's very small numbers here in the cytogenetic risk group. And in this particular, again, the PFS is better in MRD negatives. So we'll skip that. And this is the Cassiopeia trial, which I already alluded to. This has got and again, I'm sure one of my colleagues is going to go over this in more detail, but it's essentially the same Griffin trial, except it's DARA, Velcade, thalidomide, dex instead of lenalidomide. And again, this trial has a different second randomization. The other one didn't only state on whatever your arm was, but this one has a different randomization to either DARA or to observation instead of what we saw before. And when you look at depth of response with MRD negativity, when you get the DARA arm, 58% or 59% MRD negativity with the 4-drug arm versus 47 months. Now, what's interesting in this trial, which you probably can't appreciate very much over here, for the group of patients that were on the lower tier of the trial, this here, if you didn't get DARA here, but you got it randomized here, what happens is that your curves become superimposable. So if you can't give DARA up front, this proves that at least this is maintenance, but you can salvage patients by giving them DARA later. So you don't necessarily need to give the 4-drug regimen up front as long as they get it sometime during their lifetime, because it'd still be very efficacious. And this is the same data again when you look at just straight out 4 drugs versus 3 drugs, large trial, over 1,000 patients, 64% MRD negativity versus 44% negativity. And this is just rehashing what I already told you. So there are different ways to measure MRD. Most of those trials I already showed you are using next-generation sequencing, but you certainly can do next-generation flow cytometry using a technology called Euroflow, which can measure up to 10 to the minus 6 as far as MRD negativity. This is just showing the same data instead of next-generation sequencing using next-generation flow. And it still shows the split between MRD rates with the 4-drug regimen versus 3-drug regimen. So this is an ongoing trial. This is a trial that's been published. It's very, very complicated. The intent of this trial, and I think the next few trials, is to see, well, if you get MRD negative, should you change therapy, or can you stop therapy? So this is a very large trial it's ongoing. The preliminary has been published, where they get VRD and then 2 different kinds of transplant regimens, either melphalan 200 milligrams per meter squared or busulfan melphalan. They get consolidation with VRD. They get Revlimid for maintenance, and then they get Revlimid Dex, or they get Exasamib Revlimid Dex. And then if they become MRD positive, they stay on RD. If they're MRD negative, they stop the RD. So they're using MRD after this very contorted schema. They're using the MRD to decide when they can stop therapy. And what they find is that for those patients who are MRD negative, you can safely stop the therapy. The follow-up on this study is not as long as we'd like to see, but it certainly looks like you can use MRD to determine whether you should continue treatment. So these are the current large randomized trials: the IFM trial, the Forte trial, Cassiopeia, and then this most recent German trial. MRD negativities continue to improve over time, and what you find is that transplant is associated with a superior MRD in most of these trials, and that the duration of remission is superior in those patients who are MRD negative. This is a trial that was just recently published, and what they did in this trial, again, this is a phase 2 trial, a very important concept though. So this was giving carfilzomib, lenalidomide dex with daratumumab, induction, transplant, and each step of the way they're testing for MRD negativity, consolidation with dara-KRD, and then further consolidation if they're still positive, and then lenalidomide maintenance. What happens in this trial is if you had two sequential MRD negative tests, you stopped the trial and just went on to maintenance. So they were using MRD negativity 2 successive tests to decide what they were going to do next. So they're actually applying this clinically to our practice in what to do. And that's what this is this MRD sure. So it's treatment-free observation with follow-up of MRD negativity. And this is way too complex, but this is actually looking at different cytogenetic risk factors. And what you see here is the MRD negativity is very similar regardless of the number of risk factors you have. It's not that whether you can achieve MRD negativity, it's the duration of MRD negativity. This is at 10 to the minus 5th. With next generation sequencing, this is 10 to the minus 6. That's why these numbers are different. So in this particular group, the group that has 2 high-risk features, 58% at 10 to the minus 6, 79% by 10 to the minus 5th. I think we all know that 10 to the minus 6 is a more sensitive marker for MRD negativity. And what they found was, sure enough, that you see fewer cases of MRD negativity in the group that have high-risk disease, but you certainly can get MRD negativity over time. And this is, again, where they use this plan to discontinue therapy if they achieved MRD negativity. The likelihood in patients who have 2 or more high-risk features do not have a particularly pretty curve. Their MRD negativity is not very dissimilar, but the duration of remission with ultra high risk features is not as good for those that are MRD positive, or should be, even if they're MRD negative, they have high risk features. But those who do not have super or ultra high risk features, if you use this pattern of stopping therapy when they're MRD negative, the curves look very, very similar. And this was a Spanish trial, also looking at can you stop treatment if you're MRD negative. So this is transplant, and this is a maintenance. This is a maintenance trial after transplant. They had transplant, they got randomized to Rev-Dex, a doublet, or Ninlaro, Exasmid Rev-Dex. If they're MRD negative, they stop treatment. If they're MRD positive, they continue treatment. So this group at 2 years of MRD negativity, this is the group that stopped treatment. This is the group that was positive, and we see a significant difference in the progression-free survival in the group that actually stopped therapy. Meaning, again, you may be able to use this to determine clinical pathways and clinical decision-making. And this is too complicated. It has to do with PET CTs and MRDs. So this is a United States of America trial. This trial's been published. We're actually updating this right now. I'm one of the people updating this trial, but it was 3 different groups. One group got just 1 transplant maintenance, one got transplant consolidation maintenance, and the other one got 2 transplants and maintenance with lenalidomide. I'm not showing you, for this has been published a few years ago, but what this is supposed to be showing is that when you use mass fix testing instead of typical flow cytometry or next generation sequencing, when you use mass fix, this is another technology to look for minimal disease. What you find is the patients who are MRD negative and mass fix negative have a superior outcome to those patients who are mass fix positive and MRD positive. So this is another potential test that you can apply to patients instead of just next generation sequencing or for next generation flow cytometry. And yet this is another comparison looking at MRD negative versus MRD positive, and it's using not only routine immunofixation, it's also using mass fix as well as flow cytometry by next generation flow, and it's showing the sensitivity of these tests. IFE is the least sensitive to predict long-term outcomes. Mass fix can be used in the absence of the availability of next generation flow or next generation sequencing. So it is another technology to look at residual disease. And this is a comparison of those 3 technologies: IFEs, serum immunofixations, mass fix, or next generation flow, showing that the group that are negative by any of those technologies do better than those that don't. So there are currently a number of trials with clinical endpoints. I'm going to show you, this is one of the international trials. It's a maintenance therapy after transplant of DARA with lenalidomide or lenalidomide alone, so a doublet versus a single drug. And the endpoint for this trial is MRD negativity, is not read out yet. This is another trial that's using MRD negativity to determine the subsequent therapies. That's an ongoing trial. And this list is only a partial list of MRD adapted treatment. So these are all looking at MRD to help decide on treatment outcomes and treatment pathways based on MRD negativity. So there's a lot of questions about what to do with MRD. So for patients who are MRD negative, can we stop treatment? There's some preliminary data that says you can. The follow-up data is not very mature. There's some preliminary data, yes, that you possibly can stop treatment, but should you stop treatment? I showed you high risk versus standard risk. Sounds to me like the high risk patients probably need to stay on it, even if they're MRD negative. That's probably not the group that should stop, but again, this is premature. Can we actually cure people that are MRD negative? I don't know. It's certainly a surrogate marker. There is no universal test for MRD negativity. In the United States, there's only one approved company, but a lot of centers have their own testing for looking at MRD negativity. The clinical trials all use central labs, but if you look at a clinical trial at my institution, you look at a clinical trial at Mayo Clinic, we're not using the same technology to measure MRD testing, so it's hard to compare between trials because the technologies are not exactly the same. Should we use next generation sequencing? Should we use next generation flow? Should we use mass spectrometry, mass fix? How often should we check MRD? Should you do it every 3 months? Is it like CML? You should do them every 3 or 6 months. No one knows how often. Most people agree in the International Myeloma Working Group definition of MRD negativity is those that are maintained for 1 year or more. But all the trials have different criteria, what the issue is for MRD negativity. Can you use peripheral blood? That's one of the latest interests in solid tumors is using circulating free DNA. Can we use peripheral blood and look for MRD negativity instead of subjecting our patients to bone marrow biopsies? There is a company in the US that has peripheral blood that's available. The accuracy or the sensitivity of that test is 10 to the minus fifth, where most of the current standards are 10 to the minus sixth. But that is a question to avoid doing routine bone marrows on all these patients. And finally, for those patients who are MRD positive, you've gone through 3 different sequences of therapy, you're MRD positive, should we change therapy to try to convert those patients to MRD negativity? And no one has the answer for that. We have some answers that maybe you can stop treatment if they're MRD negative, but we have no answers if we should change therapies to try to induce MRD negativity in that population. And with that, I'll stop. Thank you.
Thank you very much. And the paper is open for the discussion. Professor Skotnicki, please. We have a microphone.
David, wonderful, as usual, lecture. You always start our session, and great pleasure for us. My question depends on the patient who remain MRD positive, and they could survive for quite long, and they obtain plateau. Do you think that there is the role of cell-mediated immunity or T-cell-dependent immunity in keeping in check those patients who have MRD, who remain MRD positive, and they could survive for long? Correct. As we know that immune system is very important in MM patient.
Correct. So that was why I showed the historical perspective that I know, because I have some of those patients that are still alive 20 plus years that have never been in remission. So, but the MRD would probably predict a percentage of patients that are more likely to stay in remission for that period of time. I wouldn't disagree with that, but if we can convert, which is a whole different concept, the patients back to an MGUS state, they're technically cured, and they're still MRD positive, or they're still IFE or SPEP positive.
Thank you very much.
Any other questions? If I can ask Professor Vesole, having heard your lecture, it seems that we know that patients with MRD negativity are doing better. However, we still don't know how to use this in the clinical practice, because the last slide with your question and with a number of trials which are using MRD as a sort of endpoint shows that we don't know how to use it. So my question is, do you think that we should do MRD testing in outside clinical trials, or it's a wasting of money? And let's say we choose to do it because we want to learn, even at our institution, how our test is doing. Should we tailor our decision to the MRD result?
So my personal opinion is no, because I don't act on the MRD positive patients. So unless they're in a clinical trial, it's a whole different situation. I clinically do not do MRD testing because I don't know what to do with the result, because I don't change my therapy. In 2022, I don't change my therapy for MRD positivity. So I would not recommend it as a routine test.
Okay. Any other questions? Professor Hołowiecki. Microphone is in the middle.
Thank you very much for remembering the very important concept of Barloghi total therapy. You started with this beautiful demonstration of his results. And the very comprehensive review you just gave us concerning MRD, in the matter of fact, shows the same. In myeloma, stronger treatment, we have to add, but safe, according to this Hippocratic principle, means better, because it gives deeper response as a rule, and we have lower MRD level, and this translates to better survival measures. Looking to the future, I would like to compare it a little bit with acute leukemia, where we are a step ahead. Since long we know MRD is very important, and we use it in clinical practice. But now we came to a moment where MRD should be probably made based on stem cell, leukemia stem cell count. And this is why I would like to ask whether we know anything about plasmacytoma stem cell.
I'd have to defer to one of my more learned colleagues. I am not up to date on unique biological characteristics of the myeloma or the plasma cell stem cells. It's got its own little group of people that they've been trying to figure out, first of all, which that cell, how you identify that cell for 30 years, and what it actually means once you find it. I'm not sure. I defer. I don't know.
We will come to this point. And regarding assessment of MRD in blood, this was question number 5 in your concluding remarks. So we have a very nice principle recently published by a German group concerning acute leukemia. It was proved that in NMP1 positive acute leukemia, where we can make very accurate molecular tests, the MRD tests from the blood and from bone marrow overlap. So this is a good message.
We're learning.
For
I
patients.
mean, we've made all kinds of improvements and recognize this stuff, but it's an ongoing process. I mean, it really is a very exciting time to the cell biologists, and it's a fascinating field. And yes, leukemia is far ahead of us. If you have residual MRD positive in leukemia, you change treatment or you continue treatment. We're not to that point in myeloma.
And what's the definition of MRD study now in myeloma? Which technology? What kind of markers?
Well, so that's what I was saying. So I don't know which.
Each study differs.
Each study is using a little bit different technology. A lot of centers are using the next generation flow, the Euro flow that was started by the Salamanca group in Spain, and it's kind of everywhere. But again, and our center actually uses that. But other places use their own, definitions of how they measure the flow, and the next generation sequencings are all the same. So it makes it very confusing.
This will come, that we will have a common agreement. LeukemiaNet made guidelines for how to measure it in leukemia. So probably this will come also for plasmacytoma.
Right.
I think in the interest of time, we have to finish our presentation. So thank you very much for your outstanding presentation.